A very good morning. I'll be talking about role of extracorporeal liver support in patients with acute liver failure in adults. So what I'll do is in the next 15 to 20 minutes, I'll keep myself very brief. I'll take you over to a real life case which we had recently in the ICU and just let you know because this field is evolving and there is dearth of literature. So I'll show you how extracorporeal liver support is very essential in the management of these patients with acute liver failure. Now, this is a 22 years old male who had presented to us with 5 days history of fever, jaundice, and altered sensorium. And this has progressed to grade 4. So the jaundice to encephalopathy time was just 2 days. And he was initially received in the ER where his hemodynamics, he was stable, his IVC was collapsible, he had a compensated pH and a normal bicarbonate, the lactates were 6, and he was comatose, and the ONSD that was done in the emergency had shown a high ONSD of 5.1 and 5.4, suggesting cerebral edema. He was taken over through the ALF corridor and had a CT brain and the CT volumetry done, which had shown there was significant cerebral edema on the CT brain, and the volumetry was less than 1,000. So volumetry is a very important prognostic parameter. So this patient had a liver volumetry of less than 1,000, and we can see here the bilirubin was not that high. It was just 8.5, and the INR at receiving was around 5.1. He was intubated in the ER and transferred to the ICU. His first-line investigations had shown hepatitis A virus positive, but because he was also worked up for transplant, so we had all the labs available for him, so the second and third line workup were all negative. His sepsis screen sent on day 1 from the ICU was also negative. So we were dealing with a patient of hyperacute ALF with a jaundice to encephalopathy time of 2 days. Etiology was hepatitis A, but he did not meet the King's College criteria and he had severe cerebral edema. But we were expecting that in the next few hours he's going to meet the single criteria for the transplant. So he was managed in the ICU. All the routine measures of neuroprotection were followed, the hemodynamics were maintained, he was given empirical broad spectrum antibiotics, the glucose levels were monitored and maintained, and N-acetylcysteine was given to this patient. Cerebral edema care, good nursing care, minimal stimulation, head and elevation, all that was followed, along with sedation and paralysis, which we use propofol in these patients and fentanyl, IV mannitol, and 3% normal saline to target the sodium of 145 to 150. Hyperventilation we do not consider as the first go, but yes, we keep the PCO2 around less than 43. So when you see this patient managed in the ICU at 12 hours, we see that the INR had gone up to 6.1 and the ammonia was rising, the lactates remain at 6. He was counseled for an emergency transplant, but the family has no available living donor. So what do we do next? Should we keep doing these things, keep seeing the worsening, or should we do something else for this patient? So there comes the role of extracorporeal liver support, and then we'll be discussing in the next few slides briefly about acute liver failure and how do we select out the right patients and how we can improve the outcomes of these patients with the use of these modalities. So when we talk about the phenotypes, like I said in my patient, this patient we were dealing is a hyperacute liver failure. Now what is very classical about these patients as compared to acute and subacute is that the jaundice to encephalopathy time is short. They have severe coagulopathy. So like we saw in our patient, there was severe coagulopathy, they have severe systemic inflammation, cerebral edema, and there is a need for an emergency liver transplant. But also, the recovery rates of such patients with good intensive care can be excellent, and you can salvage a lot of patients even if they meet the criteria for transplant from the illness. However, when you compare, and the important thing is that they are not deeply jaundiced. Many a times we see the bilirubin is also in the range of 4 to 8. When you compare these patients with acute and subacute liver failure, the subacute is the one who do worse because they have poor liver regeneration. The severity of jaundice here is more, and you see that they would not have developed intracranial hypertension early on in the course. The acute follow an intermediate course between the two patterns. Now, etiology is also very important because when we'll be looking at the literature, it is important that we know that the literature which comes from the West from acute liver failure mainly comes from the paracetamol etiology. So in UK, in US, the predominant etiology of acute liver failure is paracetamol, but what we see in India is the viral etiology. And therefore, the outcomes, when we look at the different modalities and the care that is offered, also might be different, and the prognostic scores may be different. When you see all the etiologies and the studies which have done from India, we look at the AIM study from Dr. Shalimar, we see here hepatitis A virus. This data comes from 1986 to 2015. We see 2% were just hepatitis A, and hepatitis E was the predominant cause, 28%, and a large proportion of patients were having cryptogenic etiology. Dr. Seema Alam from ILBS in the pediatric literature, we see again 2011 to 2016, 39% of the patients were having hepatitis A, hepatitis E in just 1.8%, and again they do a very extensive workup, so cryptogenic etiology was seen in just 14.6%. Dr. Pameja in the liver transplant series had shown the hepatitis A to be there in 13.1, and again we see more of cryptogenic ALFs going for liver transplant, so again overrepresented in the transplant population, 27.8%. So this just shows that yes, we are also seeing a trend in the change in the etiologies of acute liver failure. Now, we'll also talk about systemic inflammation and immune dysregulation, because these are the key components that are responsible for mortality. So what happens is, whenever there is an acute hepatic insult, there is hepatocyte death, and there is a failure of hepatic regeneration. There is release of these damage-associated molecular patterns, and these damage-associated molecular patterns will cause the activation of the innate immune cells, the monocytes and the neutrophils, and this damage causes the release of pro-inflammatory cytokines, which further impairs the already impaired liver regeneration. The hepatocyte death results in loss of hepatocyte function. There is impairment of the ureagenesis, complement synthesis, coagulation proteins. Ammonia and lactate are important parameters which tell us about this liver hepatocyte death and a sign of metabolic failure. And as a part of the systemic immune dysfunction, what we see is the development of infections and also the driving of the hepatic and extrahepatic organ failures. That is very common and very quick and rapid in these patients. Now, the important part about immune dysregulation in these patients is that you can see the patient in two different causes. So when you see these patients early in the course, there is significant systemic inflammation, hepatocyte death. Apart from that, there is gut dysbiosis, bacterial translocation, which is driven by systemic inflammation, endothelial dysfunction, and this subsequently not only results in the dysfunction of the other organs, but also results in a state of compensatory anti-inflammatory response syndrome, which leads to the development of difficult to treat infections in these patients. Now, obviously, we know liver transplant is the ultimate savior for our patients, but how many of our patients are able to get a liver transplant which is required in these patients? So transplant is not so easy, and we see from our center itself, we see here that a very small proportion of patients, even though with a very rapid response team that we have, we're not able to consider liver transplant the way they would require in the first 12 to 24 hours. But there is also a very difficult decision of considering liver transplant and making these very difficult decisions because of the dynamicity, the rapidity of the illness, and now because we have these extracorporeal liver support modalities, we see that many patients who meet the transplant criteria can be saved without transplant. So to go for rushing in for a too early transplant may not be ethically right, and we should not be also delaying the transplant, and we should therefore be looking at a very good optimal transplant window of around assessment of these patients after good intensive care and reassessing them dynamically that whether they need to be taken up for a liver transplant or whether they have a potential for a spontaneous hepatic regeneration. Now, the other way why we look at liver transplant and these extracorporeal liver support is not only they can cause an improvement in the transplant-free survival outcome, but also they can prevent the development of this compensatory anti-inflammatory, the immune dysregulation which sets in these patients. So it's also important to save them and keep them optimized for a liver transplant and save them from all these complications of refractory intracranial hypertension, bleeding, infection, and the development of multi-system organ failure. So all these are the challenges that we need to see and while managing these patients. Now, cerebral edema. Now, it's intriguing that none of these scores that we do not have any parameter or surrogate for cerebral edema. So the King's College criteria does not have that, but we see in different series from the West and from the East as well, cerebral edema. So the King's College criteria, even though specific, can miss a lot of patients who would require liver transplant because of the cerebral edema. And if you look at the Indian series, and these were the series where extracorporeal liver support was not done in most of the centers and the patients were managed according to the standard of care, we see that only 13% from the PGI Chandigarh series and from the AIMS, 18% with cerebral edema was surviving without liver transplant. So cerebral edema is a sinister problem, and we should definitely have scores looking at this problem. And from the AIMS, we are well versed that there is a score, the ALFIT score, which incorporates ammonia at least, which is a surrogate for cerebral edema. If we go forward from here, and we look at the data from the King's College, very nicely, they have shown that if you look at the in-hospital survival in patients with acute liver failure, it has been improving, and this is mostly in the paracetamol etiology of ALF. And what they propose is that the prevalence of ICH has decreased from 52% to 30% concomitant to see this improvement and decrease in the mortality, and this has stemmed up from the use of possibly the extracorporeal liver support, as I'll show you in the subsequent slides. Now, the mechanism of cerebral edema is also important because this is what we need to understand, that we should also be having therapies which treat the pathogenesis. The cytotoxic edema is due to high ammonia, and this ammonia is due to suppressed urea cycle and the hepatocyte non-function. And this ammonia then, because of the disrupted blood-brain barrier, goes into the astrocytes, cause astrocyte swelling, there is increased glutamate, there is increase in the interstitial fluid volume which causes vasogenic edema, there is suppression of the cerebral metabolic rate, but increase in the cerebral blood flow. So all these components, the oxidative stress, the disruption of the mitochondrial function in the astrocytes is responsible for driving the severity of cerebral edema, and therefore the strategies which counteract and improve this, the systemic inflammation, oxidative stress, and clear the ammonia are important strategies for managing cerebral edema in these patients. Now, the management, as we said, the routine management we all do, but what has come up in the last few years is the role of artificial liver support systems, which has improved the management and helped us in managing cerebral edema and different complications in these patients. Now, when we talk about extracorporeal liver support, why we still do not have too much literature and why everybody cannot say that this is the ultimate therapy, because when you look at the ideal system should remove the water-bound toxins, we should remove the toxic vasodilators, maintain the acid-base balance, fluid overload, correct the coagulation which is disrupted in this patient, and should be able to provide the support 24/7. But the most important factor which is required is the selectivity of removing only the pathogenic metabolites and molecules, which currently, unfortunately, we do not have, as of now, an artificial liver support for our patients with acute liver failure. So what are the currently available artificial liver support systems? So we have the renal replacement modalities, which could be convection or diffusion based. The continuous renal replacement therapy is the most popular amongst them. We have the adsorption modalities. So we have the cytosorb. We are not using it here, but in Europe, many centers are using in their case series. The double plasma molecular adsorption, the combination modalities which remove the larger molecules, the MARS, Prometheus, single pass albumin dialysis system, and there are other modalities, plasma exchange, which we'll be discussing. So when you compare all these modalities, the most important thing while choosing a modality for our patient is what will this modality remove? So if you're wanting to remove the small or the middle molecules, you can go away by using the continuous renal replacement therapy with a convection or a diffusion mode. But when you want to remove the larger solutes, the inflammatory, the immunoglobulins, the protein-bound toxins in patients with acute liver failure, you need something like a MARS, or you need a plasma exchange, or maybe an adsorption filters can do that work for us. But the problem is, again, the capital or the cost of each therapy. So some therapy may be very good, for example, MARS, but we may not be able to use it for our patient because of the cost and other challenges. The complications and the adverse events are other factors which decide which modality has to be chosen for which set of patients. So we'll talk first about the continuous renal replacement therapy, because we see that acute kidney injury, again, this data comes from West. In paracetamol, it is seen in 50% of patients with acute liver failure. In viral, it may be seen in just 1/3, but we see that it is associated with worse outcomes. The AKI in these patients could be either a pre-renal AKI, it could be related to the systemic inflammation or nephrotoxicity. And we need CRRT in these patients for not only management of the volumes in the context of AKI, but also the two important aspects, non-renal indications, is the hyperammonemia, the cerebral edema. And also, what we need to understand is that when you're using CRRT, can we use an intermittent hemodialysis? So we do get ammonia clearance with intermittent hemodialysis, but it may cause a worsening of the brain injury and cerebral, and this is one ideal context where intermittent hemodialysis should not be used, and continuous renal replacement therapy is which should be offered. If you look at some literature, if you see here, the patients who with hyperammonemia, why hyperammonemia needs to be tackled? Because it itself is a marker of poor outcome, and even though there is a non-linear correlation, that is, if the ammonia is high, we know that the outcome is worse, but if you have reduced your ammonia, you do not know whether you've done the good for the patient. So it may not have a linear correlation, but we know that high ammonia is a sinister sign and should be tackled. The need of vasopressors, and if the patient goes on to require renal replacement therapy, has AKI, grade 4 encephalopathy patients, and systemic inflammation. So these are the patients who need to be aggressively managed. Hyperammonemia was shown by Dr. Bhatia also. A lower level of 124 micromoles was bad for viral related ALF patients. And again, if you look at from this study come from Dr. Jalan's group, where they showed that hyperammonemia could also be correlated to the cytokine response in these patients, and they showed a good correlation of the intracranial hypertension with the IL-1 beta, IL-6, and the ammonia levels. So inflammation correlates with ammonia and the severity of cerebral edema in these patients. So what does continuous renal replacement data tells us? This is from the US acute liver failure study group, 18 years retrospective study, 50% of paracetamol. We can see here patients who were given CRRT, the lactates were high, as was the ammonia, and so was the patients who were treated with intermittent renal replacement therapy. And we see a very good clearance of ammonia with CRRT as compared to the patients who did not receive renal replacement therapy or patients who received the intermittent renal replacement therapy. And what was interesting was they showed that when they divided their patients into two eras, where they were not using CRRT for all patients versus era 3, where they were using CRRT exclusively, they showed that with the use of intermittent hemodialysis, the mortality of the patients was higher. The hazard was 1.68. However, with the usage of CRRT, the survival, the score of renal replacement therapy and the mortality showed an improvement in survival with the use of RRT. So that is the difference, and intermittent renal replacement therapy should be avoided in these patients. And they showed that this correlated with the improvement in the transplant-free survival. The usage of CRRT between day 1 to day 7 showed a concomitant decrease in the cerebral edema and also improved transplant-free survival. Now, how do you write a prescription for CRRT? And most of the resident centers have their own protocols. Some start with a higher dose because it has been shown that a higher dose of CRRT correlates more with ammonia clearance. So should we be starting with very high dose of CRRT? We do not know about this. So there are studies from the West which show that it is not only doing CRRT, so we know that CRRT is good, but the timing, the intensity, how you write the dose and the duration, all these are key factors while you're using CRRT for our ALF patients. And this is a small study, comes from New Zealand and Australian ICU setup. And here again, 85% of the patients were having paracetamol etiology, and they were saying that they just produced their data where they were using CRRT not for stage 3 AKI. So none of these patients had stage 3 AKI, 26% had normal serum creatinine, and these were sick patients with respect to liver failure. They had grade 4 HE, most of them, 81% and 88% were on mechanical ventilation. But you see here, the survival which they showed was 76%, and again they showed a good ammonia clearance and longer durations of CRRT and high dose intensity of 43 ml per kg, which was the mean dose which was given to their patients, was associated with better outcomes. And the same group recently again showed in a retrospective analysis that when you start CRRT very early in the first 6 hours of presentation, you feel you get very good outcomes as compared to using a late CRRT. So this is what they showed, that the survival, even though the patients were sicker where the CRRT was initiated early, but the survival was better in this set of patients. Now, the modality of dialysis, whether we should be using CVVHDF or CVVH. So this again, very small series of 4 ALF and 8 ACLF patients, they showed that the ammonia clearance doesn't depend upon which modality you use, but in our setting, we are always using CVVHDF. We do not use CVVH in our patients with ALF. Now, when you look at the outcomes, this I've already shown that, yes, CRRT is shown, and this is a recent meta-analysis which has comprised all the data which has just shown you in the retrospective series, and this also includes a study from our center by Chetan Kalal on mannitol, and this showed that CRRT is showing an improved survival and should be considered for managing patients with acute liver failure. Now, the recommendations of different societies from EASL, SACM, the American College of Gastroenterology, even though there are no RCTs, but everybody recommends that early use of CRRT in ALF in the absence of renal indications could improve survival. Again, we do not know the exact way to do dialysis in these patients, the dose, and what should be the anticoagulation but most of the protocols that are used is anticoagulation free. Now, the next important modality where there is evidence in patients with acute liver failure is the role of plasma exchange. Plasma exchange, when you compare with CRRT head-to-head, conceptually sounds more exciting, because if you see here, whatever you want to remove in acute liver failure, you're just removing one part, that is the middle molecules and maybe middle molecular weight cytokines with CRRT, but with plasma exchange, you're able to remove the entire milieu. You're able to improve this endothelial dysfunction. You can improve the cytokines, all the large damage associated molecular patterns, and you can also replace. So you're also replacing with fresh frozen plasma from healthy donors, so you're able to also reconstitute the milieu. So this should be an ideal modality for management. The data for high volume plasma exchange comes from the Larson group. We are well versed. I know everybody knows about this trial, but they were using a fixed, and they did not give us the exact protocol, but they were using a filtration-based TPE. How many sessions they did for all ALF, irrespective of their onset, etiology, and they still showed that it was working in the set of patients where they were considered to be transplant ineligible. We did a very small study of 20 patients looking at a low volume strategy, because when this paper came from Larson's group, we used to ask our blood bank to help us and support us with high volume exchanges, but we were not able to get it done for our patients. So we thought, let's do a standard volume plasma exchange and see the outcomes. And so the patients who had no transplant option were considered to be randomized to this trial, and this was compared to the standard medical treatment. And we showed that in patients, so majority of these patients were having hyperacute viral related ALF, that constitutes the predominant population that we see. We found a very good outcome of 75% versus 45%, and all these patients patients had cerebral edema, and most of these patients, 84%, were mechanically ventilated. So these patients have very bad outcomes, we know, as was seen in the standard medical treatment group. There was an improvement with plasma exchange in the systemic inflammation scores. Arterial ammonia did not show much reduction, and we'll again discuss about it. Optic nerve sheath diameter showed improvement, so was the SOFA score, but all these parameters we know will get improved after we use plasma exchange. But what was the important factor? The growth factors were also getting reduced. So plasma exchange may not be so exciting for us to be used on a consecutive basis, and we do see development of infections because the plasma exchange is not selective. It removes the protective growth factors, the important complement proteins, and therefore it is important that you do a response-guided approach. So it is a good therapy. It removes the damage-associated molecular patterns. It can restore microcirculation. But we need to also know the adverse events. So these are the different studies, and these are the only 2 randomized control trials. Rest all retrospective series have shown that a low volume or a standard volume strategy can be safely done, can also improve the vasopressors in these patients. The sessions, again, we do not know the exact number of sessions, so a response-guided approach is something which is recommended. The adverse events have not been reported by most of these studies. We had reported adverse events. We found 40% of these patients had developed metabolic alkalosis, 35% had developed circulatory overload, and 35% had developed infections, which we associated with the usage of plasma exchange. So 1/3 of these patients had got sepsis, which was managed. And we can see here, rest of these studies have not shown major complications of the therapy. Now, the prescription of plasma exchange therefore leads us that how do we write a prescription? A standard volume is something which should be used. That is what we follow. And a response guided. So it is not that we write, we'll do 3 sessions for everybody. We have to see the patients dynamically, see the response of each patient, look for adverse events, look that we do not, these patients don't get immunosuppressive with these, and time it early rather than late, and don't forget to reevaluate your patients at each stage for a liver transplant. So the response to TPE, when we had done in our analysis, we found that there were patients of viral etiology who were responding more, and most of these patients who responded better had a response in just 1 to 2 sessions. So if you get your response and you start to see improvement in all the parameters, no rebound increase, we know that the patient had started to regenerate. But they are the slow responders where we found that they had higher SOFA score at onset, they had thrombocytopenia. So these could be 2 markers to say that your patient may not respond, and these patients should be reassessed for liver transplant. And here they often required CRRT concomitantly. 75% of these slow responders require more number of sessions, and the non-responders were the one who had presented to severe metabolic acidosis, and all these 100% were female patients. So PLEX has been recommended to be given as grade 1 recommendation by all the societies, and they are silent on, but they have recommended a high volume strategy because that comes from the largest trial globally. And if you see at the problem with the PLEX is that if you see the ammonia clearance, so this is from the Larson trial and this is from our study, we see that the ammonia clearance is just modest with PLEX. So what do we do about ammonia clearance? Is PLEX alone sufficient, or should we be using CRRT, or should we be using a combination? So what we believe is that a combination of CRRT with PLEX is better, but again, we do not have data, but I'll just show you from this own study from our group, where when we stratified these patients, we were using in the group with TPE and CRRT versus a standard medical treatment group which just received CRRT in the patients who had renal dysfunction or for hyperammonemia. We see that the arterial lactate, the mean arterial pressure, and the ammonia reduction was better when we were using a combination of CRRT and plasma exchange. Now, when you compare MARS, so MARS can do whatever things you can achieve that by using a combination of TPE plus CRRT, and at the same time you can avoid all the disastrous complications, the coagulation dysfunction. So Mars, whatever we want to remove the larger molecules, we can use CRRT to maintain the vascular balance, because you see metabolic alkalosis, volume disturbances when you use plasma exchange. So combination therapy looks better as compared to using either alone. The liver assist device is being developed by Dr. Jalan, and this was a pig model of acute liver failure, the DILIV, which they have now published for alcohol-related hepatitis. So I feel this could be a very exciting modality where we cannot use plasma exchange, where the patient has presented to us with infections, and using DILIV, because this combines the function of CRRT, endotoxin removal, and TLR4 antagonist. So this therapy could be very good, and we're looking forward to this therapy in the set of patients where they have presented with ARDS, where we cannot do plasma exchange. So different set of patients, different extracorporeal therapies. So I'll go back to our patient because he was awaiting liver transplant. They wanted time. We proceeded with exchange. This is he required 4 sessions of plasma exchange. After day 2, he was initiated on continuous renal replacement therapy. And what is interesting, the patient who was meeting transplant criteria, almost single criteria and cerebral edema, this patient, with the usage of combination of CRRT, we were able to give him a transplant-free survival. So what I did in the last, from 2010 to 2024, we have seen 413 patients of ALF. What I tried to do is to see at the practice patterns and outcomes and how it has affected. So when you look at, so I divided the eras into 2010 to 2016 as era 1, era 2 as 2016 to 2020, and 2020 to 2024. So what is the difference between these 3 eras? The main difference is, when you look at our practice patterns have changed. We were not using plasma exchange and CRRT at all from 2010 to 2016. Only 2 and 4 patients had received. From 2016 to 2020, we started using plasma exchange after we did the RCT, and we were using CRRT in non-responders to PLEX. And from 2020 to 2024, now we are going and using CRRT immediately in the first 24 hours. So let's look at the different the age of the patients. If you see, the pattern has also significantly changed. We were seeing more of adult, means 38 was the mean age, but when you do the post-hoc analysis, era 2 and era 3 was not showing any significant difference. The age is the same, the etiology. We see here 80% of our patients now are hepatitis A, and when we were seeing initially 16% were viral, indeterminate etiology remains the same. The KCH criteria did not show much difference. But when you look at the outcomes here, so our mortality was 67%, it dropped down to 58%, and now it is down to 49%. So our proportion of patients who are surviving has increased with the use of these techniques of extracorporeal liver support, and we may do better in future, we hope so. And our transplant, almost 1/3 of our patients are still requiring transplant, but we're seeing a better, and this is significant. There's a significant decrease, and we can, same as the King's College, we can also report this data. But the important thing is, how do we assess these patients for liver transplant? So this is what we have developed from but we can also validate. We have developed a dynamic score because we use plasma exchange and CRRT, and none of these scores have these components. We also have optic nerve sheet diameter, and we feel that this score could be very good, and we would like this to be externally validated, which is a dynamic score and incorporates most of the factors which get changed with the usage of these therapies. Thank you.